I'm very pleased to introduce Dr. Zulfiqar Bhutta, whose research contribution in the fields of child and maternal health are truly singular. This is a person of unbounded energy who holds the chair in child health at the Hospital for Sick Kids, affiliated with the University of Toronto, and is founding director of the Center for Excellence in Women and Child Health at the Aga Khan University, and other appointments. He has also made a real difference at the global level in policy through his work with international organizations such as the United Nations, WHO, and Dr. Bhutta is known as a great organizer of research and is the hub of many research initiatives. He included Kyrgyzstan in a multi-country study of child stunting, and all of us were surprised to see Kyrgyzstan as an outlier among countries with similar levels of economic development, and for the first time, an outlier in a positive sense. I remember his presentation at the Ministry of Health. The staff beamed at the results and said, well, at least we did something well. His topic today is, by the way, he's now doing a study on child and maternal health in Tajikistan, and IPPA is involved with that study. His topic today, which is newborn health determinants in Kyrgyzstan, what can be done, is based on the recently completed study that was published in Lancet. And a Russian translation of that article is available on IPPA's UCA website. It's research report number 61, Тенденции и факторы младенческой смертности в Kyrgyzstan. So this is available in Russian. Please download it and circulate it to people who would rather see the information in Russian. So thank you, Dr. Bhutta, for agreeing to do this. I know how busy you are, and we look forward to your address.
Thank you very much, Bohdan and colleagues, for this invitation. I mean, Kyrgyzstan is increasingly looking like second home to me, given the number of projects that we are doing and have done and hope to do. And in particular, I want to thank you for the Russian translation of our paper. So the study that I'm going to share with you today is published. So I have absolutely no hesitation in saying that these are data which are extremely important from a global policy perspective. But before I start, let me just confirm that you are seeing my full screen view and not the presenter.
No, we see your notes, so go full screen.
Okay, so let me just change that to the full screen, and here we are. So this study was undertaken just very recently in the last few years and published completed just before the pandemic broke and published in Lancet Global Health. And the study was based on an assessment of progress in Kyrgyzstan in relation to newborn health, but it also focused on child health and relative change. What I'm going to do over the next 35 minutes or so is to talk to you about the rationale for the study, the methodology in some detail for people to understand key results and policy implications. The background to this is very much the Sustainable Development Goals. I mean, with the Sustainable Development Goals targeting progress till 2030, everybody's looking at speed of progress. So whether it is on maternal deaths, people want to see how you can accelerate progress and take it down all the way to 2030, 2035. Whether it is stillbirths, you're looking at a major increase in the rate of decline for stillbirths. And also for newborn mortality, everyone wants to see an acceleration of change, irrespective of where you were in terms of your progress in the Millennium Goals era. So there's a lot of interest in looking at how the stands have done and how Kyrgyzstan has done in particular, partly because of the whole issue of data. And Bohdan and I spoke about this a short while ago. And the issue around the data is very simple. Although it looks as if Kyrgyzstan may not have done as well as some other Central Asian states, and you can see in this particular slide of maternal mortality trends that Kyrgyzstan ostensibly here in the red dash line seems to have lagged behind others. But everyone recognizes that the data may be not as transparent, and what we may be seeing here is not necessarily, with the exception of 1 or 2 Central Asian countries, of reflective of what's happening in other parts of the region. When you come to neonatal mortality, everyone recognizes, however, that Kyrgyzstan has done very well. So the red hashed line tells you overall progress in comparison to others. And as you can see, the rate of decline in Kyrgyzstan has been quite substantial, about 54% reduction in neonatal mortality from about 24 per thousand live births to 11 per thousand live births. And these are UN IGMI data. So the rationale for the study was to enhance the evidence that we have around progress in child and newborn survival and health in Kyrgyzstan. And the idea was to develop some priorities and recommendations in terms of how Kyrgyzstan could do better. The research aim was to undertake this in a comprehensive and systematic manner, recognizing that we would need to undertake a fair amount of descriptive analysis, policy and program analysis, and importantly, a new decomposition to understand how neonatal mortality change took place between the late 90s and currently. And we also modeled some interventions to see how Kyrgyzstan could do better. So a little more detail on the methods. As I've mentioned, there was a systematic review undertaken on whichever was published from Kyrgyzstan, irrespective of language. It took us some time to get all of this reviewed. And the overall data on really looking at drivers of change for newborn health in Kyrgyzstan were very limited. They were just restricted to a few gray literature studies done by UN agencies. But we had a wealth of data. And the wealth of data in Kyrgyzstan, in addition to what was available globally from Institute of Health Metrics model data, the surveys that have taken place in Kyrgyzstan, the multiple indicator cluster surveys and demographic and health surveys. But we discovered that there was a gold mine of information in Kyrgyzstan on the National Birth Registry in the Ministry of Health that nobody had mined or looked at in terms of quality and information before. It had been, of course, used for internal policy making, but it was principally not probed or interrogated for the question that we had around newborn survival. So it required a fair amount of data cleaning and standardization to put all of these together, the surveys as well as UN data. And the National Birth Registry itself was checked for both outliers and completeness. This took us about a year to complete. And we are very, very grateful for the collaboration with the government and particularly the Bureau of Statistics, Ministry of Health, to ensure that this data was cleaned and readied for analysis. We used the 2013-17 time period for this registry, largely because the 2012 introduction was incomplete and was only a pilot phase. So the staggered rollout still allowed us to look at this last 5-year time period. We calculated age-specific mortality counts, and we estimated what was available from Kyrgyzstan in terms of the total birth cohort with what were the global estimates for birth cohort for completeness. If we had a difference between the two, we would have worried around whether we were losing any data, and I'll show you those results in a minute. And we specifically probed, because these data are not available anywhere else, on the cause of death analysis for newborns, stillbirths, and maternal deaths in Kyrgyzstan. The maternal conditions we need to probe a little bit more, and that's maybe a future study that we might undertake in collaboration with partners. But certainly for newborns and stillbirths, we were able to look at the data in detail. Just for the audience, that we did multivariate analysis using Oaxaca blinder decomposition to look at what could have influenced change in Kyrgyzstan over the last 2 decades. And this is a very difficult analysis for Kyrgyzstan because everything is so good. Generally, the decomposition looks at change in coverage of various interventions to help determine what led to change. And in Kyrgyzstan, the big challenge was that most interventions were already so high that when you put them in a model, particularly in terms of those immediate factors that you see here, it is largely the distal level in changes and some of the intermediate factors that jump out. So we'll talk about that as well when I get into the results. So let me turn to the key findings. So what did we find on mortality? So first of all, on mortality, it's fairly clear that in relation to global average in this black line here, Kyrgyzstan, even as far back as the 90s, and this may reflect the Soviet system, was already in a very good place with less than 100 maternal deaths per 100,000 births. And this is something which has remained. But the overall rate of reduction in maternal mortality from available information has not been huge. So Kyrgyzstan is still stuck at around 70 maternal deaths per 100,000 live births, which is a figure that is a bit high given all the other investments that have been made. And I mention this as area for future research because I'm sure that there is more to it than meets the eye. In stillbirths, however, Kyrgyzstan has made progress. And in comparison with the global average here in black, where the rate had come down to around 13 per 1,000 total births. Remember, stillbirths include also live births and stillbirths in the denominator. But Kyrgyzstan has had quite a lot of information from its birth registry data that you see over here in this orange line at the bottom. And here you begin to see that the averages around stillbirths are close to the same rates that we have for newborn deaths. So there is an unfinished agenda of stillbirths that we need to look at. When you come to child mortality and newborn mortality, this has been a very fast rate of progress in Kyrgyzstan, one of the fastest in the world, and it's an exemplar in many ways. And newborn mortality is also reduced from about 20 per 1,000 live births to the current rates of around 10. And what you see over here in green are the actual national birth registry data. The other ones are UN estimates, and you can see how close they are. And therefore, the national registry appears to be quite robust and quite valid. Well, the one way of checking the validity of the registry is to look at the number of births. What do we have in the registry compared to what is estimated by the UN, particularly population division? So the UN population division will give us a figure close to around 145, 150,000 births annually in Kyrgyzstan. And the number of births in the registry, if you exclude the pilot phase, have been very close to this. I mean, there is slight overestimate because we are capturing additional births also then compared to the UN average figure. But to us, this was fantastic because it meant that the registry was more or less complete. And you can see this also in terms of its distribution nationally by oblast, both in terms of registered births and also in terms of registered deaths, that it tended to follow what was the general tacit knowledge in terms of this being clustered more around areas like Bishkek, Osh, and Jalalabad. What about trends for neonatal mortality by regions? And we evaluated this by oblast based on the birth registry data. And clearly there is a difference. And the difference largely relates to perhaps the types of newborn illnesses that are presenting to the major cities. So you will see that Osh is an outlier all the way through and has had quite significantly high newborn mortality rates throughout this time period, although this gap seems to be reducing now. But you could very easily see where we are with the three outliers that appear, Bishkek, Osh, and Talas. And I will talk a little bit more about what is the quality of care issue in relation to those differentials. We see this also by region. So this is a map of the distribution of neonatal mortality by rayons in Kyrgyzstan. In 2013, you begin to see by 2017 a significant change. And if you look at the distribution of change reflected here, there are many areas where rates of reduction in neonatal mortality have exceeded an average percent reduction of 2%, which is pretty good. I mean, we look at a reduction rate of anything north of 2% as being exceptional. And there are many regions in the country that have had that, but there are others which are red flags. So when we presented this data, of course, Bishkek, because of the tertiary hospital and referrals to it, appears high, but there are regions where people should be able to see very clearly why the rate of reduction is less than both regional and national averages. So one next important question was, when are these newborn deaths taking place in relation to time of birth? And let's start with stillbirths, where I think the data need to be improved somewhat. So globally, the proportion of antenatal and intrapartum stillbirths is about 50-50. That about half of the stillbirths in many LMICs occur during the process of childbirth, and as development improves, they go down. In Kyrgyzstan, it appears that that proportion of those babies who are dying during childbirth is only about 15-20%, and the rest appears to be antenatal. Now, that may very well be true and reflect the quality of care in pregnancy, but this needs to be double-checked for misclassification because it is a bit low compared to what the global averages are for low and middle income countries. Most of the newborn deaths are early. And if you see the distribution of deaths here, by day 3, about 70-75% of all newborn deaths have taken place. And particularly on the day of birth, the first 24 hours, you can see a fairly high clustering of deaths. And that helps us understand the etiology and what needs to be done in terms of interventions. So you can see this a little better distributed in terms of first day of life, very early in the first, beyond the first day in the first 3 days, late 3 to 7 days, and late neonatal deaths, which occur after the first week. And the important thing to recognize here is that over time, there is some reduction in deaths on the first day of life, which is good because that means quality of care is improving. But the change in the first 3 days is not very great. And therefore, one needs to perhaps look at the quality of care in the first few days of life as a big driver of change. Next question was, which are these babies who are dying? Who are they? And to do this, one had to look at the babies who are low birth weight in relation to timing. These are babies who are born small. And here the important thing was that this proportion of deaths in the early period of very small babies appeared to have begun to come down in the last few years, but they have been replaced by a slight increase in late neonatal deaths after the first 3 days. So late early neonatal deaths reflect those who are surviving the first few days, but only dying in the latter part of the first week. So this is also food for thought in terms of what may be happening in quality. Babies who are being kept alive or are being saved in the first day or two, but they only die about 5 or 6 days later. What should happen overall is that this entire proportion should go down, that early neonatal deaths, very early neonatal deaths, and late early neonatal deaths should all come down proportionately. So there is some room for improvement here. In terms of normal babies, babies who are above 2.5 kilos at birth weight, which are normal sized babies, fairly similar story, but there is virtually no change, as you can see, in the very early newborn deaths in the first 3 days. And many of these babies are dying because of preventable conditions. So this is the low-hanging fruit in terms of improving quality of care for newborn infants in Kyrgyzstan. Now, this is a very important slide from the global perspective because these data are just not available at scale for any country, although they have been modeled and they are available from respective research studies and small subset analysis. And this looks at mortality rates for babies according to size at birth by both prematurity, those who are preterm as well as small at birth, those who are term, small at birth, growth retarded babies, and those who are normal. And as you can see, the normal and the growth retarded normal babies are pretty good. I mean, they're right down here, very low neonatal mortality. So Kyrgyzstan needs to be congratulated for overall very low rates of adverse outcome in this subgroup. But when you go to preterm babies, you have ostensibly around 10-folds of greater change in mortality. But the highest rates of mortality are in the babies who are both small and growth retarded, born before their time as well as born too small. And this is where interventions can make a difference, both before birth in the mother and after birth for the baby itself. We do know that this group has the highest risk of not only adverse outcomes by mortality, but also long-term developmental outcomes. And therefore, this is a very important finding at population scale that we published, and I hope will receive policy attention. And in terms of the timing of these deaths, again, if you were preterm and small for dates, the subgroup that I'm talking about, most of these deaths are in the first week of life. Okay, we now to the main issue. How does the quality of care reflect some of these newborn survival and mortality? And here we wanted to look at tertiary centers, and there are only 3 tertiary centers in the country. Tertiary means those that provide a high level of care. And these 3 centers are in, 2 are in Bishkek and 1 is in Osh. And as you can see, clearly there is a higher rate of mortality because very sick babies are referred to this place. But the important thing to recognize is that this gap in the last few years has come down, but is really not reducing too much. So we still have that differential between what's happening in other centers, secondary care centers and primary care centers, and what's happening in tertiary care centers. And you can see this by the categories. And in this category that I've talked about, premature, very small babies, the mortality rates in tertiary centers and secondary centers are much higher than primary centers. But the big question to me is there should be no deaths in primary care centers because these babies ought to be referred. So if there are some deaths still taking place by birth registry at this blue band, which is primary care level, that means there is an inappropriate referral pathway. So that's the low-hanging fruit in terms of what Kyrgyzstan can achieve by appropriate referral and appropriate targeting. The next section that I'm going to speed through is really what do we know about etiology? What kills these fetuses and newborns? And broadly speaking, the data from Kyrgyzstan are consonant with the global knowledge on this. So if you take antenatal, which is before the process of labor starts, and intrapartum stillbirths, we have a lot of conditions that relate to intrauterine hypoxia in the antenatal stillbirths. And that's not very clear as to why that is happening, and hence the need for better understanding if there is a misclassification or whether these pregnancies are with complications such as abruption or interruption of blood supply to the fetus. But when you come to intrapartum stillbirths that we really would like to see the end of, the most common causes of deaths are related to maternal care, birth asphyxia, and also intrauterine asphyxia of the fetus. And as remember that these rates of stillbirths are about the same as newborn deaths. When you look at newborn causes of deaths for small babies, 3 big killers, potentially 4 jump out. And they relate to prematurity and infections, as well as issues that relate to complications of prematurity. So prematurity is a very big cause of newborn mortality. And there hasn't been much change between 2013 and 17 from the national registry. For larger babies, the important thing to recognize here is that the big gorilla in the room here is this large 60% category, 61 to 63% category called others, that has not changed very much in Kyrgyzstan over the last 5-6 years. The big reason for that is that the diagnostics and the classification of infections in newborn infants is very, very preliminary and primitive. There are not good bacteriology centers. And as a result, we think that there is a lot of misclassification of infections going on here, which represent currently a very small percentage, 2%. We think this figure is much higher than this just from the qualitative data available and a few subsets of studies. So those are buried in here. I hope that in the next few years, we'll have a better understanding of what's happening. And then when you come to prematurity and the causes of deaths in preterm babies, it's the same killers that I just spoke about: complications, RDS, brain hemorrhage, and things that are preventable as quality of care for preterm babies improves. We are very keen to see a better representation of maternal causes of death and maternal conditions that underlie newborn deaths. And this is our current assessment from the registry. It took us a long time for us to assemble this. But you can see that almost half or 3 or 2/3 are related to maternal conditions that are eminently preventable: hypertension, preeclampsia, and other maternal disorders plus prematurity. So these are things that can be averted by good public health programs. But as I mentioned, we need a better understanding of this. Let's now move on to what are the interventions and the status of care in the country that could be potentially open to mitigation strategies. And here there are standard interventions worldwide. I mean, we put together in almost now 16 years ago a set of cost-effective interventions that were important in reducing mortality. I updated that about 7 years ago in the Lancet, with available interventions being able to reduce a lot of the deaths, and these were the focus of the Every Newborn Action Plan that is still in play. We hope to improve this by next year with the publication of the update. But to cut a long story short, these are not rocket science. That if you take the 3 big conditions that I've mentioned in Kyrgyzstan, and you look at the range of interventions that are potentially available that could make a difference, there are only about 7 or 8 interventions that are important for reducing child mortality and newborn mortality. And this is well within the grasp of public health officials in Kyrgyzstan: essential newborn care, resuscitation, kangaroo mother care, preterm labor management using steroids, and essential newborn care with cord care. So these were things that we had in mind in terms of what we needed to do, and particularly focusing on the care of small and sick babies. But let's look at the status of intervention. And I've shown this slide many times, and we published this as part of a Lancet paper, because I think Kyrgyzstan is a role model for many Muslim countries in terms of the amount of equity that we see in many interventions. Each one of these dots here represents an asset quintile. So the difference between the poorest and the richest, for many of the interventions that relate to family planning, even though these rates are a bit low, antenatal care, maternal care, postnatal care, skilled birth attendance, phenomenal. When you come to skilled birth attendance, everybody delivering in a facility, you can't even tell the difference between the rich and the poor. And we can have a long debate on why that is the case, but obviously Kyrgyzstan achieved that through decades of investments in primary care and in an egalitarian health system which provides access to everybody. This is a fantastic slide, and it was a real refresher to see this. I use this all the time to tell people it can be done. Kyrgyzstan may not be a rich country, but it has got great richness of history and great richness of egalitarian values in primary care. And you see this clearly also by oblast. When you look at various oblasts for quality of care for skilled attendants and facility-based births, they appear to be very similar. But look at the care in relation to breastfeeding, postnatal care for babies and mothers, huge differences between various oblasts. And that is where I think a lot of interventions need to come in. You will see this also for contraceptive availability, modern CPR, and that may relate to resources and uptake, but the differences between oblasts represents also to some extent differential targeting and perhaps different quality of interventions. And you see this over time when you look at change, annual percentage change for things like contraceptive use, antenatal care, that it is not uniform across the country. There are some areas that have done well and others are lagging behind. You will consistently see up here in the north that those changes are less than others in terms of improvements. And also you see this for facility births, postnatal care, and importantly for early initiation of breastfeeding. There is an opportunity to do better, particularly in Osh City. We found that the annual percentage increase was around 4 or 5%, but in other places there actually was a reduction in rates of change for breastfeeding. In our decomposition analysis that I mentioned, when we looked at what drove reduction in neonatal mortality in Kyrgyzstan, we could explain about 83% of change. And a lot of that related to the things that you see on this slide, like early initiation of breastfeeding, but also family planning, population size, and interventions that related to a reduction in poor people living in certain areas. So ostensible explanation for some of the improvements in neonatal mortality over this period of time, but we seem to have got stuck at around 10%, which we need to improve. So what more could Kyrgyzstan do? So in the last part of my presentation, I want to just focus on the policy analysis that we did on the basis of what was available. And Kyrgyzstan has had a lot of policies, laws, legislation, and programs. They can be broadly divided into key programs for regionalization, Manas Talimi, and some programs around developing of programs for maternal mortality and social determinants called the Den Suluk program. And these were all looked at in terms of how they were implemented. And they led to the development of the National Perinatal Care Program, which has been in place for almost a decade and a half now, which did talk about regionalization of perinatal care, establishment of transport system, a quality improvement program, and a differentiated financing system for perinatal care based on provision of services. The problem is that I don't think this has been implemented with the level of rigor that was needed. And that's why when WHO and UNICEF did their assessment, they highlighted a number of gaps that could be overcome in various parts of the health system by implementation of clinical protocols, guidelines, better improved diagnostics and laboratory capabilities in the country. We don't have to be entirely done in the public sector. They could be done in the private sector as well. And criteria for transportation and referrals. Remember, I showed you how many small babies are still dying in primary care setting. That should not be happening with an emergency transport system in place. So we wanted to see if investment in this area was worthwhile. So one of the first things to do is to say to policymakers, if you make this investment, how much difference can you make? And it was a modeling strategy undertaken by my team called the LifeSafe tool, which looked at scaling up of interventions in various areas. And to cut a long story short, here is what we found, that you could save close to around 2/3 of all the current excess neonatal deaths in Kyrgyzstan by implementing a simple set of interventions that you see up here. Many of these are maternal interventions to reduce maternal malnutrition, and others are care and management of infections and small babies, which can be done in any facility with appropriate attention to quality of care. And the impact on newborn lives may not be in tens of thousands, but they are significant to overcome the current burden of premature and unnecessary mortality. And remember, for all of these interventions that reduce mortality, there will be an impact on morbidity or adverse outcomes as well. So to conclude, ladies and gentlemen, Kyrgyzstan has made tremendous progress in reducing under 5 and newborn mortality, and it now stands at the cusp of achieving SDG targets. It has achieved this through an equity-focused set of interventions, and it has also implemented a data system which is second to none. And I think this can be improved further by enhancing its linkages to laboratory capacities. So our recommendations can be divided into 3 parts. One for maternal care, I think we need better quality data for mothers and newborns. We need linked data between the mothers and newborns for allowing better identification of pockets for targeting. And as I've already mentioned, something on addressing stillbirths. This high burden of preterm small predates births with adverse outcomes, that there is a clear need to address maternal nutrition and micronutrient deficiency in Kyrgyzstan. That's a practical intervention that can be implemented tomorrow. And a linked maternal, newborn, and child health registry, I think, should be the target of the government. For the care of small and sick babies that I've highlighted, we believe this is entirely within your grasp. And now in these centers, the residual mortality can be overcome with very low-cost CPAP ventilation systems, investment in a transport system that is based on triage and transport, a training program which can be done for health staff using virtual methods with link to accredited fellowship training programs. Kyrgyzstan needs highly qualified professionals. And I was surprised to find that there are virtually no people who have trained in countries which are very willing to receive people from Central Asia, including my current country of residence here in Canada, or the Aga Khan University, where we have training programs. And again, I've talked about improving microbiology services. Finally, information systems. I need to say no more about this to say there is the backbone of an already fantastic system in place, and it needs to be upgraded with the new ICD 11 or 12 criteria for classification that will help improve international comparison and analysis and link to an infection control prevention and surveillance program. So let me close, ladies and gentlemen, by acknowledging the team that worked on this. And I want to particularly thank UNICEF for its financial support to this particular project, and my own center for contributing in kind to the Aga Khan University and SICKIT Center for Global Child Health, and the Ministry of Health in Kyrgyzstan, who were great partners in terms of helping us undertake this analysis. Well, thank you very much for your attention. And if there's time, I shall be happy to answer questions.
Wow. Thank you very much for this lecture. It's extremely rich in content. Anybody, I don't know quite how we're going to do the questions, because I don't see the participants and I don't see raised hands. Does Elita, do you see raised hands?
Yeah, we have at least one hand from attendees, and if
Okay,
we can ask our technical team to help us to upgrade them so they can use microphone.
Yeah.
would be great.
Thank you very much. I was the first to raise my hand and now receive opportunity to ask my questions. Thank you very much, Zulfi. It was really great. I understood many things I didn't understand before. So I personally is a great beneficiary of this presentation. My question is on the initiation of early breastfeeding. You had a slide, one of the slides where you showed the coverage of different interventions by quintile. And expectedly, in most cases, the richest quintile was the best performer. Well, they have more resources, they can do it earlier. Except this one, with early breastfeeding, exactly reverse order, more or less.
Yes.
And my question is, do you have clear answer for that? I guess you have, but also, is it kind of typical? It's global picture also, or it's specific for the country? Thank you.
That's a fabulous question, Roman. Some people might think it's a planted question because it's been asked at times also, but the reality is that breastfeeding rates are indeed lower in the relative rich globally. It is changing in the West as better understanding, education becomes available. And the reason is people are able to afford formula. So, you know, when you're able to afford an alternative breast milk substitute, you tend to use it. There are also more professionals in some of the richer quintiles who are working, and therefore their tendency to exclusively breastfeed for longer is also limited. Thirdly, unfortunately, they deliver in facilities, many a times in private facilities, I'm talking in the global context, where breastfeeding is not necessarily what people offer because they want to give the mother rest and what have you. So the finding in Kyrgyzstan that rates of early initiation and exclusive breastfeeding were lower amongst the rich is not at all surprising. And but we were surprised to see that the gap was not that much. In most cases, we see a much bigger gap. So it does mean that the program is still having an influence, but it could be tightened a little bit more to make sure that it is just as egalitarian as the rest of the interventions.
Thank you very much. I think there is another question from Chris Gary. In written, yes.
Can you read the question?
Should I read it? Because
Yes,
I have
please. Please.
So there are two comments from Chris. One, great paper, thanks. Apologies if I missed this. I'm in a meeting while trying to listen. How do you account for the smaller decline in newborn mortality in Kyrgyzstan compared to elsewhere in Central Asia, particularly given that Kyrgyzstan is seen as a role model and has prioritized this area through several health reforms? That's the question, first question.
So I think there is a real data plausibility question here, and without putting my foot in my mouth, I will say I believe data when I have it. And for many of the Central Asian countries, there isn't the level of granular data that I have seen or worked with on Kyrgyzstan, and I am, as Bohdan pointed out, working in a couple of other countries in Central Asia, where you cannot even be certain about coverage within DHIS, leave alone having a central birth registry. So my answer to the question is that while I may expect that for certain countries in Central Asia, like Kazakhstan, there is probably a lot of investment. It's a very rich country in healthcare and health systems. Maybe Uzbekistan to follow, but what I've seen out there, I think Kyrgyzstan has a health system which is second to none for newborn care, with the exception of some areas that need to be improved. So there is a plausibility and I say credibility question. So I would say on the plausibility and credibility check, the data from Kyrgyzstan are a lot more believable and plausible as compared to many other parts of Central Asia, where I think those are model data, and model data can be completely wrong.
Thank you. And there is another question from Chris. Also, what is the role of the change in demographic dynamics in the influence in newborn and maternal mortality during the study period? In particular, I have in mind the substantive increase in overall fertility rate, particularly among the adolescent age group and in rural areas.
So that's a great question. And that's a question that did arise because of the reduction in modern contraceptive prevalence rates, particularly with the downturn that happened with the interruption of supplies. And that was something that we looked at in the birth registry by maternal age. We could not find a signal on that in the period that we looked at till 2017. But I'm itching to get back and have a look at what has happened since 2017, particularly during COVID, because there could very well be a reversal of some of these changes. And particularly because as a direct effect of the US policies on not supporting family planning or commodities related to family planning in the last two governments, particularly the Republican government. And that reversal of the trends and the Mexican protocol has had an influence on family planning program coverage all over the world. We are currently looking at family planning exemplars also worldwide. And I think the point that you ask in terms of what may be happening in demographics in countries which are affected by that reduction in family planning coverage or CPR availability is a real one that needs to be answered by more recent data, particularly covering also the COVID-19 pandemic. So I wish I could answer that with greater exactness, Chris, but that's my feeling right now. But within the period of study, we did not see a signal in adolescents in particular.
Thank you very much. I think Damir has a question.
Yeah, I thank you for the great talk. I really feel proud from one side, given the findings you presented. In your early charts, when you showed mortality rates among oblasts, it was clear that Osh city and Bishkek coming on top. If I would interpret this data, can we think that people with complications come to more or less center to get treatment, and in that respect, statistics reflects that desire of people to come to proper health care? And does it also mean that if we intervene more or less targeting those areas, that things can also improve?
Yes and no. So I think that differential in terms of, and we should look at that by population weighting also. So we have never therefore highlighted those as problematic areas, except to say that in certain categories of neonatal mortality, availability of secondary, high quality secondary and tertiary care should also be a factor in reducing mortality. Most of the world has now referral centers, and therefore, you can reduce neonatal deaths due to asphyxia, etc., through that mechanism. What we found in Osh city and in Bishkek is there are still very high mortality rates for babies who are born preterm and small, the category that I showed you as the problematic category. And that rate of mortality is very high for facilities that have that service available. So I can understand persistent high mortality if you only had primary care. But if you had secondary care and if you have tertiary care, then that mortality rate should come down over time. we don't see a trend in that reduction in mortality in the 5 years that we looked at. But it would be worthwhile looking at this now, again, let's say in 2022, 5 years on. Are those things continuing to improve? Are they leveling off? As I've already said, we were surprised to see that most tertiary centers did not have high quality microbiology services. And we could not see data or find data for neonatal infections, which is such a big category of newborn adverse outcomes. And I think that is something that can be improved, particularly now with the advent of molecular biology. Most people are now moving away from classic old microbiology with agar testing to much more molecular methods. So there are ways of doing this, which I think are cost effective for Kyrgyzstan. And I hope that the government took our advice seriously, when we made it.
Are there any other questions? Let me ask you a question. So when you're talking about infant mortality and all of that, the health of women, and the health of women is absolutely critical. And I think it was using Life in Kyrgyzstan panel survey, there was a group of scholars, Charles Becker and others, who wrote an article called Forced Marriages and Birth Outcomes. That women that were either through arranged or forced marriages, that the weight of the child was significantly was different if that marriage was of a voluntary nature. So I don't know how big the difference, because I can't remember the data from the article. But I wonder about that factor in explaining some of the differences and causes of infant health, infant mortality.
So Bohdan, that's again a fantastic question, and it's an important question, which unfortunately cannot be answered from the data available, because the National Birth Registry does not give us data on what marriages are forced and what are not forced. But the link between maternal mental health, stress, and adverse birth outcomes is very well established. And as I understand, many of these forced marriages are also in young girls, in adolescents. So there is a nexus between them. We could not explore this in our quantitative analysis because, as you recall, when we were doing this study, the most of the focus was on quantitative data perusal. We could not do any qualitative studies, which we will in another iteration would like to do. So it's a question to be determined if in the low rates that we have, there is a subfraction of maternal mental health, maternal stress. And you may very well be right, because in that subgroup that we have as preterm small for gestational age, that's a reflection of an adverse birth outcome, which is usually a product of toxic stress. So you have malnutrition, but you also have maternal mental health issues. The end result is the baby is born too early and born too small. So we have already said a big chunk of newborn mortality in Kyrgyzstan is related to that subset. And that subset, we have offered solutions that come out from our modeling, which is maternal nutrition improvement, micronutrients, but it could also include reduction in coerced marriages. It could also include reduction in adolescent pregnancies. It could also include maternal mental health support. So you may very well be right. I just don't have the empiric data to answer that.
Very good. Do we see any other questions?
Yes, we do one more question. Yeah, yes, you see it, right?
So it's less epidural painkiller. I mean, no way of knowing this by comparison, because the birth registry data was incomplete for the quality of care during childbirth. So one way of looking at that is to look at birth outcomes by women using epidurals versus no epidurals. But very few birth registries are set up for that kind of detailed questions. But it's an interesting question. Natural childbirth versus assisted childbirth. I'd be surprised if you find a signal on this, but it's a question that can be probed.
Any other questions? Well, thank you very much, Dr. Bhutta, for a great talk. I remind the participants that this paper is available in Russian from the IPPA UCA website. It's a working paper that has much of the data. I know some of you, Dr. Bhutta had to go through the screen, through the slides quite quickly. There you can take time and peruse it, and it's.
And there is also a more complete, fuller report from UNICEF on this in English, as well as in Kyrgyz and Russian. That's available from the UNICEF website. So they can look at all of the detail in the UNICEF report per se. But may I thank you for your invitation to speak to you. As I said, we look forward to our continued collaboration with UCA, with Roman and yourself, Bohdan. And it's always a learning opportunity to work with people in the same time zone that more or less I'm in from Pakistan. So thank you.